right. Our first speaker for today's opening plenary session is Thomas Sullivan. He is the president of Rockpoint Corporation, which was founded in 1995 to provide continuing medical education to physicians around the world. Rockpoint is a ACCME accredited subsidiary, Potomac Center for Medical Education, and is among the nation's leading medical education companies. Our speaker is editor and author of the popular website Policy and Medicine that covers important regulatory issues affecting the pharmaceutical and device industries. For 5 years, Policy and Medicine has been ranked #1 by Google as an information source for the Physician Payment Sunshine Act, which some of us have heard of. Policy and Medicine has been quoted in the New York Times, the Wall Street Journal, and by CNN. He is also one of the founders of the Association of Clinical Researchers and Educators, a nonprofit education foundation dedicated to showing the value of industry and physician relationships. He is co-founder of CME Coalition, a lobbying organization for CME providers, and has been successful in educating stakeholders in Washington on the value of CME. Prior to founding Rockpoint, Thomas was an award-winning television producer and political consultant. His clients included Republican congressional committee candidates, campaigns for Congress, governor, and U.S. Senate. He began his career working on Capitol Hill and in the Florida legislature. I think we're going to have an interesting talk. Thomas is going to talk on the Affordable Care Act and research. Where have we been and where are we going? Please welcome Mr. Sullivan.
Well, thank you, Cheryl and Eric, for having me. I think it's an honor to be here in Denver. I would say that yesterday I went looking for a piece of clothing that I needed that I'd left behind, and I went into a shop, and he said, "Are you looking for the dispensary?" I said, "No, I'm looking for a belt." So there are other types of things that are going on here in Denver as well. So. And clicker. And just as a disclosure, this is a CME accredited talk. I'm a principal at Rockpoint. I own some stock in a genetic testing company called Castle Biosciences, and we get grants from device and pharmaceutical manufacturers. And as in all full disclosure, I was expelled in the first grade for switching classes with my identical twin brothers, and nuns would have nothing to do with me and him, so I was in trouble from the very early on. So just a little background of healthcare reform. You've heard a lot about it. It was talked about for a long time, but it actually has a long history. Teddy Roosevelt in 1912, as part of his Progressive Party wanted to make sure that the states paid for healthcare for everyone. I thought it was pretty nice of the federal government. They want to make sure the states paid for it. In the 1948 Democratic platform, it included universal coverage. So it was discussed under the Fair Deal with President Truman in the 60s, in 1965. 50 years ago, this summer actually, Medicare and Medicaid were passed by both houses of Congress and signed by President Johnson. In the 70s, we had managed care. Does anybody here from the 70s remember managed care and how much fun that was? We still have managed care, so it's stuck with us. And in the 90s, we tried, Bill Clinton and his wife Hillary tried to set up a healthcare reform system. They sent buses around the country, and you had the little old lady commercials that the different insurance groups had put up to try to stop that. It wasn't successful, but in 2010, all the pieces kind of came together, and we passed the Affordable Care Act. So what was kind of the forces behind the Affordable Care Act? If you're around to remember it, there was a rising cost of health care was really getting kind of out of hand. There were 48 million uninsured. Actually, right now, there's a lot less. There's fee-for-service incentives. There was just, basically physicians would send in a bill, and Medicare and Medicaid and insurance companies would just pay them. And most payments right now are paid that way anyway, but we're moving toward a value-based system. And it was just a lot of disgruntled people. I think it was just disgruntled. But I think more importantly than anything, it was a unique political environment. You had, for the first time in probably 50 years, 60-vote majority in the United States Senate, which allowed for that you wouldn't have to worry about, you wouldn't have to worry about being stopped by not being able to be passed in the Senate. And then you just had a lot of kind of good ideas that were kind of clumped together into the Affordable Care Act. So it was signed in March 23rd of 2010. Everybody remember that day they signed it. It was like a big deal. I had the opportunity at my office to have a former deputy secretary at HHS come in and kind of brief us on what was happening and where we could kind of look for the future the day after it was signed. And what was interesting is he made a statement. It was Tevi Troy. He made a statement that no Republicans have ever turned over any kind of entitlement. So as much as they like to say they're going to turn it over, and I don't know if anybody watched the debate last week, and a couple of days ago they said they were going to turn everything over. I don't look for that happening anytime soon. It's never happened in history, and I don't think we're going to be making any history anytime soon. And also the cost of care has come down. So what was in the Affordable Care Act? Kind of a big picture. There were insurance standards. I think these are probably very positive things that a lot of people really appreciated. Under 26, if you have a child under 26, he can stay on his parents' insurance. There was not discrimination of dropping people from insurance policies. A lot of people were hesitant about joining clinical trials before because potentially they could be dropped from their policy if there was an adverse event, or if they were on some kind of study drug, maybe there would be potential of being dropped. You had pre-existing conditions, so if they changed jobs, they wouldn't be able to get insurance. Also on the dropping side, I had friends of mine who had very sick children who reached their $1 million limit, and they were basically dropped off of insurance and could never get another piece of insurance again. So, that was a very positive thing for the Affordable Care Act. In addition, you had essential benefits that were covered. Now, monograms, colonoscopies, all can be, wellness visits are all paid for without co-pays in your insurance plans. And there's no cap for payments on services. There's no longer can you be kicked off of a plan just because you passed a certain limit. The ACA, it mandated reforms for an individual, basically required everyone to buy insurance. There's a big United States Supreme Court case, I don't know if everybody saw that a couple years ago, where basically they said, no, that's a tax, and you're allowed, and government is allowed to require individuals to buy insurance, just like you do car insurance by the states. The federal government now can require that individuals buy insurance if their income meets a certain level, and that there are subsidies that they give them or penalties if they don't buy it. There was an employer mandate that kicked in last year for employees over 100, and this year it'll be over 50. If you have over 50 employees, you have to have some level of coverage for your employees. And then there are the exchanges that were set up. That didn't go very well at the beginning, but it's gone quite well since then. And I think they figured it out how to set up exchanges to be able to buy insurance, and quite a number of people have joined. There was Medicaid expansion, which we'll talk about in a second, and there was also Medicare reform. And I think most of what we're going to discuss really kind of falls into the Medicare reform and some of the requirements for insurance companies. So Medicaid coverage has been adopted by 31 states, but as you can see, 19 states have not adopted Medicaid coverage. Some states, and a lot of them, if you can see, it's kind of in the South and in the central United States, and then toward the coast and the Northeast and the far West, they have Medicaid coverage. And this has affected a lot of families that couldn't afford insurance. If they live in those states and they also cover under the mandate, it's been very difficult for them to buy insurance. But I think that's going to be working itself out of the system. I think you're seeing more and more Republican governors even trying to get passage of Medicaid expansion. So what about clinical trials? So where did clinical trials fall into it? They basically required coverage for individual participants at clinical trials that began in 2014. Now, if they basically cannot deny or limit coverage for routine patient costs. This doesn't mean that they can, this doesn't mean that they're going to pay for things that deal with the study drug, but they can't, or the study device, but they have to pay for the routine patient visits, just like they do, kind of very similar to Medicare and Medicare. Now, what was exempted from that is if you were on a plan that was governed by what's called an ERISA, or you're self-insured, like Boeing is a self-insured company. And the other one that was limited was grandfathered plans. So if I was enrolled in a plan and I'm in the same plan before March 23rd, I don't necessarily have my clinical trials covered. And again, it was for routine costs that it's covered. It also has to be approved trial. So it needs to be federally funded trial, or has an IND application, or it's registered in clinicaltrials.gov. So it's not any trial that you do. It has to be specific. And then also cancer or life-threatening disease conditions. So it's limited to just those areas. So it's, if you're doing an RA trial or a trial in macular degeneration, you probably will not be able to get the routine care parts of that trial covered. So you're going to have to work, you're probably working now, as you've been in this for about 1.5 years, working with the sponsors to try to make sure that you've got the right coverage. And you can also they cannot discriminate based on an individual's participation in trials, so they can't deny coverage for that. And it does not ban or what's called preempt, which means it says it's greater than. It does not preempt state laws requiring clinical trial coverage, and there are several states that have that. So some notable limitations to the mandated clinical trial is that a insurance company can require to use an in-network provider. So if you say, oh yes, I want to sign up for a trial, I'm a patient, I want to participate, the insurance company can say, well, you have to use a doctor in our network if they're a PI in that trial. So you may have to travel, your patients may have to travel a little bit to get to the doctor that's in their network. Also, it has to require to do out-of-state coverage, but the limitation on that is they have to pay all the out-of-state fees and out-of-network fees that would normally be associated if they went to a doctor that was out-of-state. So just kind of keep that in the back of your mind for your patients. There's also additional criteria that it has to be according to the protocol. So you can't like guarantee that everything is going to be covered. The other piece kind of is if you're doing a trial and you require multiple CT scans, they may say, well, we're just going to cover the first CT scans because that's typical care, and the other CT scans have got to be paid for by the sponsor or paid for by the trial site. So what this done, though, is it's kind of causes, there's a great migration going on in healthcare. Has anybody here worked for a system, for instance, that has been bought up or changed in the last year? Anybody work for a practice or a system in the last 5 years? You've been bought up or changed? No? I would say about a quarter of the room has been bought up and changed in the last 5 years. Well, the same goes kind of for coverage in plans, as people are going to be going in and out of some of these plans. So if you're a clinical trial site and you're dealing with Medicaid and Medicare patients, pretty much they're going to stick in the trial. I don't think you're going to see much migration on those patients because their coverage doesn't really change. But if you're an exchange plan, you have to think about what's the demographics. Can these people afford the $5,000, $6,000 copay? They have to reach a limit before the insurance gets to kick in. And so, there's a lot of kind of concern if they start to switch plans. Are they going to be moving in and out of our plans? If it's a private insurance company, again, these increases in copays, is that going to change? There's been a lot of change. I just recently, one insurance announced insurance company were going to drop about 50% of their providers from coverage. So just kind of think about that. You may be in a plan right now, and in the hospital or the physician office that you work with, or the site that you're working at may be covered for their usual care, but may not be covered later. And then you also have provider migration, where private practices are being bought up by ACOs or being bought up by health systems, and then they have a whole different set. All of a sudden, you become under a different set of coverage, and you may not be covered when they move along. And then you have all kinds of other things that are going on. So this is kind of a chart you kind of want to look at is if you have Medicare, Medicaid patients, you're going to stick to kind of the same. You're not really going to move. But if you have a Medicaid patient, they're going to stay the same, but insured patients can go on to Medicaid. Maybe their income goes down. They maybe go to an insured or private exchange, or they may become uninsured. Or if they're an uninsured person, they may stay uninsured, or they may become insured in private exchanges, or they may actually go to a Medicaid plan. So there's a lot of kind of movement around, I think, on people and move. So what does this mean as far as recruitment and retention for your clinical trials? Will people still be able to obtain private payer coverage? Or will they switch to uninsured either because they lost their coverage, or will they switch to Medicaid, or they switch to Medicare, or they aged out? So there's a lot of kind of movement among people. The other thing is the insurance plans, especially the exchange-based plans, have been narrowing their networks every single year. So will those private plans still be able to cover, or will they shift them to different people that are in the network? In addition, there's the closed networks to accountable care organizations and medical homes. Their concern is they're paid for on quality measures, and a lot of what you do doesn't fit in that scheme of quality measures. So just kind of think about it. If you're working in an accountable care organization, or you're working in a big healthcare system, and they're really focused on quality measures, clinical trials aren't reimbursed as that much on the quality measures, and you're not being able to show them. And there's some things you can do, and I'm going to talk in a few minutes about to kind of help with that. And then, will subjects tolerate higher copays and deductibles? If my deductible is $5,000 or $6,000, am I going to want to go back in the next year? And you may see some migration year in between years. So you may have, like for instance, you may start out with a patient in May who's on your trial, and then he comes back up where his deductible kicks in again at $6,000, and he may drop out just because he can't afford to stay in the trial for himself. So there's a lot of kind of things. And also look for opportunistic behavior and consent language. And what this means is you're going to have patients that are going to say, I think the trial should be paying for this. And they're going to really try to negotiate some money back. And you probably don't deal with it necessarily at your level, but your backroom office people are dealing with this on a daily basis. So some of the things, and this is kind of a slide, but now I have insurance. Now I can join the trial. I'm all excited. Or I don't have insurance anymore. Now I have to join to get on the trial care. Or my insurance now covers routine trials, care and trials. I can join it. Isn't that great? Or my expanded Medicaid covers my routine care costs. So now I can join the trial. So a lot of people are going to be coming into your trials. But some will be leaving. I'll say, I have insurance. I don't need to be in a trial. Right? I have insurance. I'm not forced to be in a trial to be able to get care. I want that standard of care. I don't have insurance anymore. I can't afford the routine part of a trial. The PI is not in my network, so I have to drop the trial, or my deductibles and copays are too high to be in that trial. So leaving payments, I'm going to go to another system called open payments. Now, open payments, which is the Physician Payment Sunshine Act, was part of the Affordable Care Act. It's another one of the pieces of it. And it basically relates to reports to payments for physicians for any transfer of value to a physician. So of any payment or transfer of value. So, a pen, if they get a pen from a pharmaceutical company, or they get a cup of coffee or whatever, that's all going to be reported. And there's about 5 million payments that were reported just last year. So, there's a lot of different payments that are just gone into the system. In addition, for research, you have to report, they're reporting the payment, but they're also listing the PI. And what's that doing is you've got your PI saying, why is this $300,000 counted against me when I didn't see any of that money, but yet still it's listed on a report. When you look up a doctor, there he is, he's got $300,000, and to the average person reading this, he thinks the doctor got $300,000, right? He doesn't think that that basically went into him. He just happens to be the PI on the study. There is some things that you have to consider as a trial site, is that you have to keep a written, the research payments, in order to be in the research protocol, have to be in the written agreement, contract, or research protocol. So they have to be, in order to be a research payment, they have to be in that, and it has to be what's called an unbroken chain of contracts. So somebody has to keep records of all those contracts. I'm sure the pharmaceutical companies and device companies, the applicable manufacturers, are keeping very close watch of this. And then there's some opportunity for delay of reporting, i.e. if my drug's not been approved, or I have up to 4 years or the year it was approved to report it. Not many people opted out. I think this year more people opted out of it. So this is kind of the data summary. We have now 2 years of data. We can see that the general payments, one was 5 months, one was 12 months, so it's not apples and oranges. You can see research went up, but it was only because of the difference in months. And then ownership went down by about $200 million. And ownership isn't a payment, it's just the value of whatever the company is. So if you're doing kind of analysis on payments, that doesn't really count. So what we've seen with this is that research is about 55.8% of the payments. So it's a big piece. You have the biggest piece of the pie, so to say, and followed by royalties and licenses and compensation for services, others, and consulting, which is largely selling your companies back to somebody else. But what we did an analysis at I have another publication called Life Science Compliance Update, and we did an analysis of the Sunshine data, and we looked at the 5 months for research, and we looked at the 5 months from 2013 to the last 5 months of 2014, and what we saw was a 32% drop in total research payments. In addition, we saw a 0.93% drop in the number of payments. So the number of payments didn't drop, but the research amounts dropped significantly. And I'm not sure if it's just for reporting, or what's bringing that about. When we looked at the direct payments to physicians, it had dropped basically line for line. When we looked at what areas had been hit the most, it was medical oncology and hematology oncology. So there was a real reduction in spending for those 5 months. And again, it may just be an artifact, but it just for those 5 months, it just showed that. In addition, research and teaching hospitals saw a drop, but not quite as much. And then non-covered recipients, which most of the money went to CROs and SMOs, most of that money, which is basically a payment to a non-covered recipient, it dropped about pretty significantly month over month as well. So there's some issues kind of with open payments, which is tying the full payment to the principal investigator. Like, nobody wants to be the person that has that, right? Has anybody actually here looked at the open payments database? Has anybody been on to look up their doctor, I see about 2 or 3, 4 or 5 hands in the room, you know? That's kind of typical of these kind of databases. The government sets them up, they get all excited, they say everybody's going to go to them, and then nobody actually uses them. Anybody here been a hospital compare, physician compare? Yeah, even lower. I mean, there's just all these. There's just a lot of work to create these giant databases, and not many people go to them. So, for you guys, it's the value of the study drug. You know, every company has a different valuation. As a matter of fact, there's even one method called the Monte Carlo method. I kind of recommend not to use anything called Monte Carlo when you're going to a regulator. You don't want to use that. That's the name of our method. There's loans of equipment, you know, if they give you a refrigerator to use, and sometimes they'll count that as part of the total payment to the studies, and maybe they'll even put that in. We looked at the gift category, for instance, and a lot of that was loans of equipment for refrigerators to clinical trial sites. So if you can imagine, you know, that's like, so now your doctor has a gift against his name, or your teaching hospital, and that doesn't look good. The other thing for you guys to consider is including travel, food, and lodging in your investigator meetings and your contracts. I think that way, your doctor's he's not listed as, oh, he got all this money for food, and really it was just for speakers. That happened to Peter Libby, was written up in the Boston Globe recently. They said, oh, he's a horrible guy, he gets all this money for food and lodging. It's because he's traveling to investigator meetings and they haven't added it into the contract. So as much as possible, add those into your contract. DSMB and IRB funding. If you sit on a data safety and monitoring board or an IRB, that may be listed as consulting. It may be listed somewhere else. It's not, because it's not necessarily part of the clinical trial site. So they're going to be, doctors who have no relationship with industries. Like, what is this all about? You have third party and SMOs are not listed. So what's happened is a lot of the complaints that came back on open payments back to the companies were, hey, I never got a payment from you. And they're like, well, you did. You got it from our CRO, but there's no listing of the CRO anywhere on the database. So there's no way for a doctor to know that. So there's a lot of those kind of disputes. So Another program under Affordable Care Act was Biosimilars, which is the Biologics Price Competition and Innovation Act. This basically created a way to make generic, for lack of a better word, generic or biosimilar copies of bio drugs. Kind of really cool thing. It's been going on since 2000. They've been using this since 2006. I mean, in Europe, there are currently 44 on the world market, 19 in Europe that are approved. Of the 19, there's only 5 originator products, so I think it's going to be a long process. And then the FDA did finally approve their first one in March. It just came on the market a few months ago because of some litigation that went back and forth between the companies, but now we finally have our first filgrastim SDN is now on the market. For clinical research, just consider that a reference product has to do a study for each indication. So they have to, if you're a reference product, you have to do a study. If you want to be an RA, if you want to be in dermatology, you have to do a different study. But for a biosimilar product, you just do an immunogenicity study and then one indication study. So but this is an opportunity. There are 44 products right now in the world market. There's going to be a lot. There's probably about another 700 or 800 in development. There's going to be a lot of clinical trial work to be done on these biosimilars, and you should become kind of semi-familiar with this because this is a very big opportunity, and I think all biologics drugs are a great opportunity for research, but this is an opportunity for even more research kind of on the same, around the same kind of compounds. There are 4 sponsors that have filed in the U.S. and 5 have for 5 different drugs, and right now only 1 has gone through the system. Several have been kind of withdrawn, and there's kind of Janet Woodcock said at a hearing the other day that they're very, very cautious about approving these because they want to make sure they're right. So I think you have a little bit of time before those are approved. There are some issues with biologics. One is interchangeability. There's an opportunity to be what's called an interchangeable drug, but the originator products are getting pretty smart. Like for instance, filgrastim, they actually went for an orphan indication on post-nuclear accidents. So if there's a nuclear accident, they have a new indication on post-nuclear accidents, so you no longer can be interchangeable with filgrastim because you filed your application before they had that indication. So there's also going to be plenty of orphan trials from originator products to try to figure out new things that they can have to keep these from becoming interchangeable. There's naming and labeling. There's a lot of kind of debate around that, but FDA settled on the fact that a drug has to have a name, and everyone has to have a 4-letter extension on the end of it, so even the originator products. And I think that's caused a lot of stir, but that's okay. I think it kind of makes it fair. And then pharmacy dispensing is what's it going to mean to your pharmacist to have 4 or 5 versions of filgrastim on the shelf, or other laws? That's going to be a little bit tricky. There's state substitution laws, and then there's a thing called a patent dance that I think has kind of been thrown out by the courts recently. So lot going on in BCPIA with biologics. PCORI, you're going to have a talk in a few minutes about PCORI. I'm not going to go into great detail. I would just say that AHRQ was to build a capacity for CEDAR by establishing a grant program that provides training for researchers. And I'm not sure if she can address it later on how they've done with that, but I think that's an opportunity for training for you guys as researchers to get on this. And there's also some head-to-head files. Just so you know, PCORI has funding through 2019. I don't know how likely it's going to be for 60 votes in the Senate to be able to come up with a funding mechanism for PCORI after 2019. But they do have $500 million a year to spend, and they have plenty of programs that they're spending money on. Now, leaving the Affordable Care Act, there are some things that are happening in healthcare that are important to you guys as researchers that you're going to, in research sites, that you're going to need to kind of know about. One is the Medicare AccessCHIP Reauthorization Act of 2015, or MARCA. This, for years, doctors fought time and time again over what's called the doc fix. They wanted for the sustainable growth rate. They wanted to make sure that the SGR was repealed. And they went, fought. Finally, I don't know if the wind was behind their back or what happened, but they finally got it passed this year, and by a bipartisan in both House and Senate. It was a miracle. And what they've done is that it's basically instead of an automatic pay cut, they get an automatic 0.5% yearly increase. Now, there's a couple caveats to this, that a physician has to be part of a value-based payment model, which is like an ACO or a medical home or some other value-based payment model, or he participates in a program called MIPS, which basically, before we had 3 programs. We had meaningful use, PQRS, and value-based modifier. And the doctors had to fill out separate sets of forms for each one of those, and your health system did. And they would have to prove that they meaningfully used their EHR system, or they met the PQRS value measures, or they filled out the form for value-based modifier, which is basically based on PQRS. Well, they've combined those all into one program. And the penalties can be up to 10% of Medicare reimbursement. So it's a huge penalty for physicians if they're not in a value-based payment model to be in this portion. And so what this means is that there's now the single program goes down into one. They've added a new component, which is called clinical practice improvement activities, which research, if they were to kind of go into CMS and argue their way, could probably become a clinical practice improvement activity, and give credit for professionals working to improve their practice and future participation in payment models. So professionals will receive composite performance scores. So they're going to be on these. Basically, they took the same 3 programs and just made them into one, and they're exempt if they're again in a payment model. So for patients and clinical trials, though, if you do not have an informed consent in that patient record, if you do not have that form attached to that patient record and has to attach it, like on a consistent basis, they will not count those people as being in a clinical trial. And if they don't perform according to the quality measures, it could be pinged against your MIPS, or it could be pinged against your ACO, your ACO coverage. So you have to, whatever you do, you have to include that form. And I know it sounds boring, but you have to include that form into that piece. And it's a significant, and each time it's a significant payment of less payment. And we've seen this with physicians this year. Almost 400,000 doctors got 2% cuts in their Medicare reimbursement this year. And it's going to be because they didn't do one of those three programs. And it's going to be a lot more as they go on. So you just have to really pay real attention to make sure that you're in board with this. Another thing that's happening in less than 15 days or 13 days from now is ICD-10. Is anybody here familiar with ICD-10? Oh, good. I have a room full of people that are familiar with ICD-10. So kind of think about ICD-10 is a really big deal for your systems, in that it's going to take a lot of attention away from what you're doing. So if you need something from your IT department, get it now, because in a few days you won't see it again. ICD-9 had 17,000 codes. ICD-10 has 141,000 codes. There are some one-to-one translations, but most of it is like one to several, or up as many as 1 to 250. The other thing about ICD-10 is they're linking codes. And so what a linking code is if I'm a diabetic and I have edema and I have foot disease, I have to basically press all those into. They're all one code. So if they just put all those 3 codes in, the insurance company can reject the payment. When I remember, I'll never forget. I was in a meeting about 5 years ago, maybe 6, with this, and this woman came up. It was a healthcare meeting. This woman came up to me from Australia, and she says, "You're going to ICD-10. You're going to ICD. You have no idea what this means." I said, "No, I have no idea what you're talking about." She says, "You're going to ICD-10." She says, "When we went to ICD-10, 30% of our bills weren't paid." And I was with a practice the other day. They've set aside $2 million in anticipation of not getting paid. So it's going to be a big deal. It's going to be a big deal to your practices. So effects can be on claim submissions, patient charts, research activities, all kinds of things, and the cost is pretty outrageous. And some of my favorite ICD-9 codes, ICD-10 codes, because we might as well have a little fun with it, is because they get so specific, it's crazy. Like civilian aircraft involved in transportation accident with a military aircraft, or an insect bite. And where is that insect bite? So imagine the poor guy in the ER is going to have to, okay, where is it, and what code is that for that? a balloon collision injuring an occupation initial encounter. They actually have a subsequent encounter code too. The one that fits me is a type A behavior pattern. I have a code for myself. Stressful work schedule. Want to make sure you put that in there. It's a secondary. You can't have that as your primary diagnosis, but it can be a secondary diagnosis. And then walked into a lamppost subsequent encounter. So as you can see, there's a lot of really kind of almost ridiculous. I don't know anybody ever hurt themselves knitting or crocheting. I think they now have a code for you. Now, there is a code for the code that you currently use in ICD-9 for clinical research is only a single code in ICD-10, and it's Z00.6. So it's like a zoo. Just think about ICD-10 as a zoo. But you have to make sure it's with zeros and not with other pieces. So what this means for clinical trials is you probably, in some cases, you're going to have to keep multiple sets of records, especially for your intake forms, multiple sets. Who am I seeing? What's going on? You also have private insurance coverage may be different. They may be delaying going on to ICD-10 from ICD-9. I know that Blue Cross Blue Shield of Florida did a survey of their members. They offered end-to-end testing for their 80,000 physicians in their network. They offered it this summer. They had 1,000 people sign up out of the 80,000, and 200 actually completed it. So I think it's going to be a kind of a scary thing. I don't think many people have actually completed end-to-end testing. But your private insurance coverage may move. They're going to move over as well. I can tell you the private insurance companies are very interested in moving ICD-10 because everybody, when they do this kind of thing, they can change the reimbursement rates. I remember being in Italy before the euro, and a cup of Coke was like, I don't know, I think 150 lira or 200 lira. And after the euro, which is about 25 cents, when the euro came, it was $1. It was a euro, right? A Coke was a euro. And I think what's going to happen is they can adjust when they create this confusion. Insurance companies and payers can kind of move things around without anybody noticing it, just because there's so much confusion going on that nobody has time to pay attention. And so at the end of the day, they're going to say, the hospital says, what happened? Where did my money go? And it's going to be lost. And the other thing is they're going to have a really fun time saying reject, because nobody's going to get the codes right in the beginning, or at least 30% or so of the codes will be wrong. You have feasibility and recruitment. If you're recruiting patients, you're going to have to make sure you know what those codes are. What about longitudinal data? If you're looking at one set of patients and now we use a different set of codes, how's that going to change? You might have to go back and figure out what the code was for before. There may be protocol amendments that come out of this, and disruption to your IT systems in managing your patients, because they're all set up on ICD-9 codes. And then I think this, along with a lot of other stuff, it basically means the end of single practice. I have no idea how a single practice physician is going to be able to withhold all this stuff that they're throwing at them. And if you're from a small site with a couple physicians, you're going to need a lot of outside help to just manage all this different stuff that's going on. There is some hope. There's 21st Century Cures. Is anybody here familiar with 21st Century Cures? It's a bill that passed through the House and Senate. The House. It hasn't been taken up in the Senate. It passed 61-0 in the committee, and it passed 34-77. So this is a very strong bipartisan bill, and it basically increases funding at NIH by $875 million, and increases funding at FDA by about $500 million. But it's stuck in the Senate. I never forget sitting with the chief of staff of a Senate office once. And he told me a story that Tip O'Neill had said, and when Tip O'Neill was the Speaker of the House, they said, well, are you worried about the Democrats? Are you worried about the Republicans blocking your legislation? He said, no, I'm not worried about the Republicans. He said the real enemy is the Senate. So, and this was a Senate chief of staff said that the real enemy was the Senate. So I thought that was pretty interesting. So some of what 21st Century Cures does that directly relates to you as researchers are required standardization of data and inclusion criteria in clinical trials .gov, so you're going to have to make sure all your trials are in there, but it's also standardization. Makes de-identified clinical trial data for qualified trials available for further research. It makes research for health data part of the healthcare operations. Establishes a pediatric research network, which I think will be a kind of an interesting project when they get going. It's a structured framework for qualification of biologics, biomarkers. It's streamlining the IRB rules for multiple style sites, which we're going to talk a little bit about. The common rule that came out, the proposed common rule came out that talked about that in more detail. And it also eases informed consent for minimal risk trials. If you're doing a trial where you're trying to determine if a right-handed surgeon is better than a left-handed surgeon, you probably, you don't have to go through pages and pages of informed consent to get that through. Also, manufacturers must make expanded access policy available, i.e. they have to make sure that people know that these clinical trials are available. They'll have rare disease incentives, and then some EHR registries, some observational studies, that the FDA can use these for endpoints. So non-traditional endpoints for FDA submissions, which actually Bob Califf, who was just announced as the Obama pick for the rest of the FDA, for the rest of the term, and the FDA commissioner, actually just put out a paper yesterday on using non-traditional data for FDA approval. So I think that's kind of a way in which people are starting to look at as a way of approving products. So one other big thing for you guys is the common rule proposed change. Has anybody here looked at that at all? Are you familiar with this? This is going to be a big deal because this applies to all clinical trials regardless of funding, with exception of FDA-regulated trials. And why this is going to be a big deal is it's really going to change the way you look at how you handle clinical trials, and it's going to change the whole way you operate. Just so you know, in 2011, they went through what's called an advance notice of rulemaking, and this is a notice of public rulemaking. So this is kind of the final piece of it. This is your last time to speak up about it. A couple things just to kind of think about is they've gone from a single IRB they want to go from having an IRB at every site to having a single IRB per trial. I think that's that's going to be great for getting trials approved. It won't take you a year to go through it. They also want to kind of reduce some of the requirements for an IRBs as to what mandates a trial that you have to cover, that has to go to IRB, and they'll have a little checklist form that they'll have online that an investigator is going to go through and check off and see if he has to submit this to an IRB or not. But the one thing I think is going to affect you more than anything is a broad consent for biospecimen sample reuse. So every admission to your hospital, everywhere you think you might use a biospecimen, you're going to have to get informed consent on the use of those, even if they're de-identified. And that could be a huge blockage for genetic testing, for any kind of clinical trials where you need some kind of control group, and you just don't want to have to go out and have to sample a lot of people to get it. Now, and it's also going to really mess up the specimen banks. They did offer two alternatives. They said one was to just require a consent form. It'll be a long consent form, about 4 or 5 pages. And they said that they would actually write the consent form and give you a sample form so that people could use. But the other piece of this is that they've offered that and they're saying a couple of opportunities to this can this be is this for a total genome sequencing or partial genome sequences? So there's some opportunity to comment on this. Last year, when the CMS proposed a change to the rules around CME, I worked with the CME Coalition, which is an organization I helped set up, and we generated almost 1,000 comments to CMS. Now, CMS has had 1,000 comments from their advance notice of public rulemaking. They're going to need almost everyone. If you do not like this, or you like this, or whatever, but this one piece on this broad consent, I think if you do not like it, you're going to need to speak up very strongly against it, and it might be just everybody submitting in a comment because there's power in numbers to say we don't think this is the right way to go. So, in summary, the AHA has changed the healthcare system. I think we've seen a tremendous change in what's happening in healthcare. I think you'll see more insured patients in clinical trials. I put question marks next to this because we don't know. Does that mean more trials participants or less? Does open payments, does that mean we're going to see more money or less money to research? Well, that one analysis we did looked like it was less, but it may be more. With biosimilars, are there going to be more trials? Absolutely. I think you guys guarantee you're going to see a lot more trials coming through your doors. PCORI spending on clinical trials, we're going to hear about that a little later. Payment model changes for investigators. This is a huge thing for your investigators. A lot of your investigators, especially if they're being reimbursed on what's called RVUs or relative value units, is what they're counted at the hospital. That's going to change the amount that can participate in a clinical trial. I think it's going to be disruptive. ICD-10 is a clear disruption, and then 21st Century Cures, we'll see if the Senate passes it, but we're hopeful. I think we're hopeful. Just one thing, just to remind yourselves, this is kind of the big picture, that what you are doing is important. If you can see that if you look at deaths from cardiovascular disease and cancer, they've all gone down, and HIV was a huge problem in the 90s, and now is almost down to it's a manageable chronic disease. And you've done a tremendous work bringing about cures to things that nobody else is people aren't looking. In the future, this was a quote from the Premier of China, in pursuing reform, we have to navigate uncharted waters. We may also have to confront protracted problems because we'll have to shake up vested interests. I think any kind of reform, you're shaking up vested interests. I thought it was a great. In 2016, with the beyond 2016, it's pretty imaginable. I mean, I was reading about, patients now are tweeting out how they're doing on clinical trials. I mean, I know it's driving you nuts if you're trying to do a double-blind placebo trial, but the point is, is that access to information is going to get greater and greater and greater. And there will be ways in which we can do clinical trials which will shorten the time to treatment and actually help a lot of people out. So I think what you're doing is a fantastic job. And I just want to thank 3 people for helping me with my presentation. One was David Valcano, who's the Vice President for Research for Columbia HCA, great, interesting individual. Toby Ann Holtz at Quintiles, who's in charge of their ag spend reporting. Gillian Woolett, who is the absolute expert on biosimilars. And thank you very much.